We'll now move on to a very interesting and unique section, that is track 6, Ask the Expert Leaders and ANEI officials. We are honored to have with us our stalwarts in the field of nursing who truly embody this principle of walking the talk. May I take the privilege to welcome Ms. Abanti Gopan, who received the Lifetime Achievement Award today. Let's give a round of applause for Abanti. Ms. Evelyn P. Kannan, Secretary General, Trained Nurses Association of India, New Delhi. Ms. Kavaljit Oberoi, Nursing Consultant, Ex-Group Head of Nursing, Emirates Hospital Clinics, UAE, EC member ANEI. And Captain Ajita Nair, our ANEI President, who will be setting the context for us. Over to Ajita, ma'am, please.
Well, we are into the next session. Hope you all are alive, active, not feeling sleepy. All good? Enjoying? So we'll get on to the next interesting session, but before that, we had left with one award in the morning, right? Best Nurse Leader Award Academics was left, and the awardee's name is Dr. Kanika. Can I invite her onto the stage? And I also invite Dr. Rebecca Sampson to give away this award to Dr. Kanika. Dr. Kanika is Vice Principal of Chitkara University in Punjab. And she has done some exceptional services in her field of academics. And we would like to have more leaders like her in academics to enthuse the students and keep them engaged and all in good spirits. So I would request Dr. Rebecca Sampson, who is our founder member of Association of Nurse Executives India, to give away the award to Dr. Kanika.
Can we give a round of applause for Dr. Kanika, please?
Thank you, ma'am. Thank you, Dr. Kanika. Photo nahi liya? Some people are lucky to receive the award twice, same award. Right. Thank you, thank you. Now let's get on to our session. This is a very unique session, as was said. So in this session, we have three eminent nurse leaders. This session is for the audience actually. You know, audience can ask us questions. So there are 4 of us sitting on the hot seat, and you can shoot us any kind of questions related, relevant, let me be clear, relevant, related, important, significant questions to us, which should be, I guess, related to our field of work, and all of you know us. So, yes. That is good, Dr. Unmana, to start with. Yes.
Ma'am, my question to Evelyn, ma'am. It is by listening since morning till now, not only today, from decades back, and nurses are backbone. Yes, nurses are backbone, taking care of everything. Even in my new current hospital also, they said they are doing everything in all departments. But can't we specialize them? Whatever work they do, say like nurse educator, in government sector I'm talking, maybe private sector, all these things are there. Nurse educator, nurse counselor, nurse informatics, etc., etc., etc. My humble request to you, I know TNI is a very strong body. If you propose to, or if you collaborate with, maybe ANEI also may take step forward, but if you take the step and put into practice, but I'm hoping that it is not that it will be done, but it should happen within the year. My expectation is that the spatial is then what will happen, the nurses going out of the country will be limited. Because now we all, the young generation,
Limited.
young generation, they want the, new lifestyle, like the fashionable job and all this thing. Even name of the job, if we redesign, they'll be very happy to stay back. That is the first and foremost thing. Second thing, again, I request you, of course it has been talking around about the salary, money, okay, how we can make it. Even the people from Manipur, if they are even receiving 5,000, can you imagine? So how the people will live like this? So how we can put it forward? My expectation, these two strong expectation from you, Evelyn ma'am, and I'm eagerly waiting to hear from you. Thank you.
Thank you so much. Very good afternoon. Thank you for this wonderful opportunities you have given to us. I bring greetings from the Trained Nurses Association of India, which is only 116 years young association. We are moving ahead with a great commitment and dedication since 1908. If you see the nursing history, the TNA who brought the system of formal education in India. Because when you see this 1946 only we have a nursing, college of nursing. In up to 1920, there were no even the system of formal education. The TNA who brought the system of formal education, 100% looking forward to empower the nurses as well as the continuing nursing education is one of the major objective of the Trained Nurse Association of India since beginning. So we are always encouraging the nurses for that. Even the TNA is giving the grant as well as the workshop grant for the branches, and we are also upskilling the nurses. And TNA has a Central Institute of Nursing and Research Center also, because again the TNA also has taken initiative to establish the simulation lab in various areas. Since morning we keep hearing about this. Nurses need to be empowered. Empowered need to come, I think, within ourselves. My responsibility to empower myself. And madam's question is, we will, that means 100% agreeing, because already all the specialization courses are online, but main problem is we are not getting a proper nomenclature as well as a credit. That means that our government is not giving the legal frame, because TNA is only fighting, because many courses we may keep increasing, but we need to have the complete independent with the accountability. So the TNA also definitely working along with that, and many programs are going on with the Niti Aayog government also, and very hope soon we will get into the victory that we will be empowered, not only just keep on upskilling, with the proper nomenclature, with the proper cadre, we are working on it. Hope we will do it. Number two question is, I think way back in 2011, TNA filed a case in the Supreme Court, the minimum salary at least to be done. I think 2016, we got into, that means approved for that. At least the nurses in Delhi, they are getting a better pay. We are working on it. If we get this information about this, nurses are paying underpaid or other things, TNA is take a legal action. Not only that, at the national level, because national level is not going to help much, because that has to, health is a state subject. We need to work on it. We need to collaboratively work in it, because now already we have started collaborating with not only the government sector as well as the private sector. Very recently we had a collaboration workshop with the Dr. Usha Banerjee as well as Dr. Sandhya and various Colonel Binu. So we all, Mr. Vinod, we all had already discussion. I think we both can come together and work together on this. The nurses needs to be not only empowering with the knowledge, as well as we need to give them the better salary structure. And now again the council had taken a decision, in every branch also had given authority to take a legal action on wherever the nurses are not getting very well paid. I think in coming years, we will have a great opportunity to work together and collaborate together. This is the beginning. I really congratulate Annie to inviting me to the TNA to be part of it, and think we all together we can win over it, the situations.
Thank you, Evelyn ma'am, for that very relevant answer and for the very, very relevant question to Dr. Unmona. Just wanted to say that, there had been a lot of activities done to improve the salary of nurses, but too less and too much to achieve, So whatever we do is not enough and has not resulted in actual increase of salary of nurses in many sectors. Whereas in some places it has really picked up and, nurses have got the benefit, especially in government sector. But in private sector, some elite hospitals do give salary. But what the problem hospitals face is on the other hand, is every bit of money, naya paisa, comes from the patient. And 70% of healthcare is being delivered by private healthcare. So there is a disparity between what is actually happening and where we want to reach. But all said and done, if salary is not increased, you cannot expect and you must not expect the nurses to stay back and look after the health of this country. That is a fact that remains. So that also reminds me of this tremendous opportunity in front of us to collaborate, synergize our efforts, because working in silos, fighting ourselves is not going to result much. We have seen it over many decades actually. So the only way going forward is collaborating with each other, not only the nursing organizations. I would rather rally for the support of doctors' organizations and also the various management, because everybody's survival is in question today, right? We all are in existential crisis, actually, literally, because we don't have enough nurses to look after our patients. And those who are also, there is a lot of competency gap. So everybody is in trouble actually. The public is in trouble. They are the beneficiaries of healthcare. Okay, let's move on to the next question. Somebody is ready with the next question. Yeah. Over to you.
Yes.
Please tell your name first.
Very good afternoon. I'm Dr. Margata Mies, Professor Savita College of Nursing, Savita University. Hearty congratulations to the organizers. It's awesome, really enjoying with full of knowledge. Nice to see the leaders, especially connected from the clinical area as the leaders. Good. My question is actually to Dr. Abanti Gopan ma'am. I have seen her implementing nursing process 30 years before in BM Birla Hospital. Maybe many students, when you hear the term nursing process, you may feel not good, but I love. Then it further moved to another step, theory application, that is also beautiful. Recently, with the NPCCS students, now critical care pathway, that is another dimension in patient care came. My question is, we study, we give more importance in curriculum, but are we seeing this in practice? To bridge the gap between what we learn, what we practice. So what is the best way to do? How to convince my students to learn wholeheartedly and practice this? And as a teacher, I have full satisfaction in teaching them. But in practice, I could not really enjoy that much with 100% from my students. And that is beautiful thing for really patient care also. What we can do, ma'am?
Yeah, she asked me.
Yeah.
The question is
your question was to Abanti ma'am, right?
Ma'am, then anybody can answer.
Okay, fine.
thank you for the
It's okay, ma'am.
thank you for the question, and thank you ANEI for giving this opportunity to be on this panel. Yes, 30 years back, we have not only had the nursing care plan, even we had implemented the nursing standards. I was fortunate actually to visit the Royal College of Nursing in Oxford, where I did a short 10 days course on the dynamic standard setting system. And we had nursing standards also long before NABH was born. Now NABH has standards, and NABH has also mandated that nursing care plans have to be written at the bedside by the nurses. Now coming to the implementation part, well, if as a leader in a clinical setup, if you mandate that they will have to write the care plans, they will write it. Even 30 years ago, we had 90% of our nurses were diploma holders. We did not have postgraduates or graduates in large numbers. Postgraduates hardly, but large numbers. We didn't have BScs also. And the diploma holders actually wrote the care plans. Many of those care plans even helped us win court cases because of the documentation. evidence that whatever was done. Of course, there have been times when, because of lack of documentation, we have not got the court cases also. Both sides have been there. And the nursing care plan has also helped the other healthcare team members when they used to come on the rounds, especially documentation regarding the time of onset of infection, the process of the infection, everything. They would get this common information from the care plan. So I really didn't feel that there was absolutely any difficulty in implementing the care plan. And language was not at all a barrier, even though we have to write it in English, but they picked up and they wrote it. That time we didn't have standardized care plans either. Now today we have standardized care plans. Many of the hospitals are also going in for computerized care plans where you just have to select the problem on the computer and choose and fill in whatever the intervention has been done. So I felt that things have become much easier. And to be very honest, I really don't know why the nursing care plan is such a difficult concept today and why nurses, because every course, whether it is a GNM, BSc, MSc, post-basic BSc, every course teaches the nursing process. So I really don't understand where the problem lies and why the reluctancy. But in the clinic, but yes, one thing is that the care plan should not be, we should try to move away from the linear care plan. You know, where they keep writing the assessment, then long pages, and then the intervention. We should try and make, as I have recently, we had actually a meeting on nursing care plans. I think many of you were also there. And what I try to say is put the care plan on one page, whether it is a computer or you take a printout, whatever it is. Correlation map, where everything about the patient's diagnosis in the center and all the aspects, the clinical manifestation leading to the nursing diagnosis, with the nursing diagnosis, whatever the intervention has been done. Interventions will be medical treatment, surgical treatment, nursing intervention, and then the outcome or the evaluation, all on one page, so that not only nurses will use it, every member of the healthcare team, including doctors, surgeons, anesthetists, physiotherapists, dietitians, everybody can refer to the care plan as a central point of getting the story of the patient. But the care plan has to really bring out the story of the patient right from the day one up to the discharge day. It has to be updated every day because it's dynamic. So I really don't have an answer to exactly to your question that how to make it, but I feel if as a leader you do it, people will follow. We have to lead. We have to, maybe sometimes we have to even stand and help the staff identify the problem and write it along with them. They get used to it. Thank you.
Should I continue with the same thing? Yeah. So now when it comes to SOP, standardization and putting up policies and processes, I think in my experience, I have commissioned or rather started from the project is almost 7 hospitals. And to start a hospital, to set up a culture is the biggest challenge, right? So now what I have gone through in my journey was when I was a staff nurse in one of the reputed hospitals in Mumbai, I can name it as Jasdok Hospital, we had only 4 papers for nursing documentation, just TPR, IO chart and 1 nursing notes. But in 1990s, when I went to Muscat, that was the first time I got exposed to something called as a checklist. And that was for IV cannulation. And we were supposed to be doing 20 times cannulation under supervision to become competent. And that was the eye-opener for me, that there is something called as a checklist and there is something called as a competency checklist, and unless you don't do it, you cannot proceed as a competent nurse. This was a real big eye-opener for me. 6 years I worked in Muscat and I learned a lot, and that is a time I understood that there is something called as SOP. I never heard this term before in my life when I was in my bedside nurse. 96, when I came back to Hinduja Hospital, Hinduja Hospital happens to be the first hospital which ever went into some hospital accreditation as per my knowledge, and it was for ISO 9001-2000. So ISO standards were taken for Hinduja Hospital, and I was picked up as a resource person to set up manuals for nursing. Even today, if you go to Hinduja Hospital, there are 10 manuals, specialty manuals, work documentation manual. So there were 10 manuals, and I created this manual with one finger typing, talking to the ward boys and the IABIs and the nurses and the technicians, what is the process, how do you take the patients through? And then the manuals were created, and then the training was given to the nursing staff. When I became a nursing head and I took up of a cardiac hospital, that was the biggest challenge I realized, and we were going for JCI. How do I train the nurses? How do I set up the policies and protocols? Because it was a cardiac hospital, 130 bedded, there were about 5 to 10 maximum disease conditions. So I think it became very easy for me. Everything was a checklist. In fact, a COO told me, Mrs. Oberoi, please teach all your nurses as morons. I mean, please consider all your nurses as morons. And I was shocked. I said, what are you talking about? Why should I consider nurses as morons? They are all intelligent people. What do you mean by morons? Create checklists. And that time it really felt bad about it. Why is he calling all the nurses as morons? But when I went into creating checklists, I created checklists for angiography, angioplasty, CABG, aortic valve, all these conditions, checklists were created. Nursing care plans, standardized templates were created. Admission discharge checklists were created. I'm talking about in something like 2002, 2003, pre-NABH era. And when I created this checklist, the only one thing which I made very compulsory, which will answer your question, was mandate. Every nurse has to fill up this checklist. I know it is tedious, but for me, the attrition was very high. And for me, I did not have senior nurses also. I had my team leaders who was just 1 year GNM experienced nurses, or my in charges were just 1 year. It's very difficult for us to take the training through. So when the checklists were created, can you hear me?
Yes, yes.
So when the checklists were created and mandated, I would make supervisors check whether the checklists were filled. The biggest advantage what I found from this checklist was as if I am teaching every nurse. So every time we were filling up a checklist for angiography, preparation of a patient for cath lab, angiography, the nurses had to read that line and then say yes or no. So every time when you read a checklist, it was your self-learning. So it became like a self-teaching, self-learning tool for the nurses. And I felt that they became much more competent because 3 times when you filled up a particular checklist, you knew by heart what is the expectation for a preparation and the post-management of the patient. So for me, checklists became a big hit where the nurses were able to learn the policies and the procedures and the processes, admission, discharge, transfer, all these things were in the form of a checklist. And then SOPs were created. SOPs are created and they are not elaborate SOPs. Create as bullet points, create as short formats, create the important points where it will make or break the image or your clinical safety of the patient. So just pick up the important points and then you teach that. So every time when the shift changes, make sure, like for example in the ward, falls is very common in the wards. Make sure that before the shift, the nurses are like, it's like culture, like you say a prayer, so you just take do's and don'ts of a day, okay, so it's a revision. So I feel these small tips and tricks, when you use it in your clinical areas, and when you keep on reinforcing, that is how you make a habit and you make a culture for the staff to follow the patient clinical safety. When I was in KDA, we created a nursing module. I mean, we were given a HIS where there was no nursing module at all. So we got our this Nick Knock, what is that Nick Knock, that software? So sorry, I'm forgetting that name now. So we integrated the this nursing care plan into the software. My own nurses, I had 20 fresher, BSc fresh nurses from my college, from SNDT, who had joined me. The team sat and they created the entire nursing module for that HIS system. disease-wise, condition-wise, we had created a nursing care plan which was standard. But again, complications were taken on individual basis, because if any complication would come, then they would just pull out a paper, print out a paper, and then use it. In my experience, if we leave the nurses to sit and write down the nursing care plan, if the patient has got 5 problems, they will just write 1 or 2, which is anxiety or pain and very generic. So I felt, of course there are pros and cons, we can keep on debating on that. I felt that if you have like 80-20, use the principle of 80-20. If you feel that these are the common conditions in your ward or in your area, and it's very easy in specialized departments, units actually, create a standardized template, create a standardized nursing care plan, and then implementation, what all you feel are implementable points, morning, evening, night. I would ask the nurses, okay, this is pain, and these are the 10 points of implementation, hot water bag or pain medicine. And you just have to circle what all implementation, what all points you have implemented. You don't have to sit and write. So documentation was minimum, but effectiveness and and compliance was more, because they would just put the signatures on that, sign it off, and the result, the outcome in the knock, they would write down. For example, for pain, they would say, pain score morning this much, evening this much, night that much. We did not have that much of HIS or technological support, but most of my hospitals, we had to go into manual, but the manual documents which were created was more user-friendly, I believe, and that is where I was able to do the compliance to the nursing care plan. As Avanti said very clearly, it's not difficult, but it's a culture.
Ma'am, I guess there is more questions coming, so we should take few more questions before we finish with that. Agreed with your point. So I think just to conclude the point about nursing care plan, I agree with Madam Abandi Govan that why should there be a confusion? Because there is a lot of confusion in the people who are implementing in their mind. They are confusing the younger ones. That could be the reason, is what I feel. Now, I mean, we have to do a lot of things to clear this confusion, because for nursing care plan, for most of the nurses sitting here, is an assignment in the course, you know. So this kind of, written punishments is what is going to kill us. And that is why there is a lot of confusion, I feel, because for them it is an assignment, written assignment to be submitted to get the degree. You know, that is something like that is the concept, and that is where but whereas I don't think you both have that confusion. You know, our generation, I mean, exclude me, your generation don't have that confusion. We started
Because
the next question.
The reason was, there was not gap between the education and the practice.
Yes,
now
yes.
there is a lot of gap between the education and practice. We are
so education and practice gap is not really for the students. It is for the teachers who are teaching and who are practicing. Do not know why are they practicing that. Agreed. Next question.
Good evening. I'm Dr. Sonali Jadhav.
And I would request you to be short.
Sure. My question can be answered by any of the panelists. I just want to ask, what are your thoughts on having independent nursing practice? In 2019, the government of India launched the midwifery initiative. Today, physiotherapists have opened their clinics and doing a lot of things. I believe we have our own skill sets. What are your thoughts on that, having an independent nurse practitioners?
Okay, she's asking about independent nursing practice. Okay, so if I may answer that question of independent nursing practice so far in our country, is that do we have a Nurse Practice Act? I guess some states have. Some states have, is what I feel. I don't know. Not in its real sense. So one is legal backup as such of a Nurse Practice Act is not there. So I raised once this issue with CEO of Cleveland Clinic. He's a clinician. We had a tie-up in the Maitra Hospital where I was working. And when they came for visit, I asked this question. So what he said is that it is all up in our mind. What he said, I explained this point that we don't have a legal backup like in your country, in US. So what he said that when there is no legal backup written down, what is preventing you to take that status?
Absolutely.
You know, it is an opportunity for you. So it is all up in our mind as such that independence. Now independence also, I mean, as far as nursing care is concerned, I feel we are independent. Yes. Who is telling us what to do? Absolutely. And don't encourage nurses to write down, back care, mouth care kind of things. You know, we should tell that it's our area and we will decide what to do. But we should have the confidence to go and tell a doctor that. But if we don't take care and result in bed sore, the doctor also is answerable. So that is where the point is. So independent practice, same as that in US, do we want is another debatable question. So I'm not getting into that because there is a lot of accountability attached. So I will use my favorite word, accountability phobia. We have to get rid of that. We have to be expert in what you are doing, and we are fairly independent is what I feel. If you are an expert, you are independent. No doctor will come and question you because you produce results, right? Over to them.
Ajita, I have just to add to that.
Yeah.
We are, in the West, nurse practitioner courses, well established long back, and they are practicing independently. And even now, we are telling our mid-level managers and graduates, go up and rise in your career, and they are going for nurse practitioners course. Already it's happening. What is the future for them? When it comes to their job responsibilities, salary benefits, free practice, and even opening such courses in other specialities. What is that happening? I want Dr. Avanti and Madam also, TNA Ma'am also to answer, Madam Kannan. Okay, what is the future? Are we discussing about it in a higher level?
Let me reword it. What is the future of nurse
practitioners
courses?
Nurse practitioners. Already people have completed the course. Still
very
happening.
Few, very few, of course.
Very few. But anyway, we are a lot of waiting for the NNMC Act, how it's going to happen, because it has all the areas of teaching and practice and everything. I think within 6 months it is going to be implemented. That's what we keep hearing it. So we wait for the best hope that, and as she said that, we as a nurses equip ourselves and put it in action. We are registered nurse, registered midwife. Nothing is hindering us. Whatever the preview of the thing, we have to keep going it and doing it, and I think we can do the better.
For that, we have to be really expert in what we do. And we have to own up the outcome of what we do. This is what. So morning we have heard many people saying that there is a lot more to be done by ourselves to reach where we would like to be. And out of that, the foremost thing is taking accountability for the results of our action. If we assume that, and I'm sure a lot of senior leaders are sitting here, middle level leaders are here, those who take accountability for the result of what we do not face this problem of, independence. Yes. Occasionally, yes, but not otherwise. Abdul, thank you.
Good evening all, this is Abdul here. My question is to Elvin ma'am. What support as TNI you can give us for migrant nurses who are moving from one state to the other state in view of their licensure? Because every state council, nursing council have their own rules that it should be, the practicing license should be from the land. So we have these issues where the nurses are not willing to go and re-register in the other states. So as TNA, how can you support us in this?
Got the question. So what can we do, TNAI do to support the nurses who keep moving from one state to the other?
Because actually already the Indian Nursing Council has taken it up, and they are having one registered act is coming up. I think already 10,000 nurses are registered. That's what they say, that because they're issuing the license and bringing the standard and all the things are the regulatory body. But however, and we are also demanding this one license, one nurse, wherever they go, they need not have any problem. So we also will definitely support. But I think Indian Nursing Council is already making a lot of plans on the same thing.
Yes. So there is a little bit of conflict legally answering, because health is a state subject and it all arises from there. Health is a state subject and we are trying to centralize it by doing a, one registration. So we are halfway through, then it was fell back, and I don't know what is the status now. But hopefully it will come through. That is the only answer to have this. But at least some effort from the people sitting here, their side. NABH today does not insist on a state registration. They have to have one valid registration, and it is not a non-compliance. This was to a written complaint given. I have given, because I had a non-compliance when I was working in Gurgaon, that, half of my nurses, nobody had a Haryana state registration because they were not giving that registration. So it was a non-compliance, and NABH had listened. And then they had put it up in their website saying that at least it will not be an NABH non-compliance that you do not have a state registration. Small little steps. Yes, over to next question. I will have probably this as last question, because we have to hurry up, I believe, or one more. Then we should cut short the length of question and answer. Yeah, yes.
Namaskar, ma'am. I am Shampa from Kolkata Appelo. Ma'am, my question is now, we used to we used to prepare the nursing care plan. Previously, we have been taught that we prepared our nursing diagnosis. According to nursing diagnosis, we used to write our care plan. But nowadays, there is some means whenever audit time, it has been asked that it should match with the doctor's note. So sometimes it's a great problem for us. Like sometimes there is low albumin, doctors are not writing that much of interventions, or cardiac enzymes high, only they are writing the continue the same. There is no such as that much intervention.
I can answer your question in just one half sentence. Okay? It is not really that it should be exactly in line with doctors what they write, but there is a clause. There should not be contradictions. You know, doctor is writing and nurse is writing. The opposite cannot be that, legally it is not acceptable and we are not working in tandem. So it's a communication problem rather than anything else. Nobody has told it should be following the doctor's orders, but however, it should not be contradicting. It cannot be, because doctor writes something else, but that care we are only giving, right?
Yes.
So that is also part of our nursing care. So it will come in alignment with the doctor's whatever writing notes or their
Since she mentioned Apollo, let me clarify. It is not that nurses have to follow the doctor's care plan. The whole plan should be patient-centric, comprehensive, and holistic. And as you said, should not be contradictory.
It is not your plan, my plan, it's not. It is one care plan for the patient actually.
Absolutely.
Yes. Next person, please. I can take maybe
Very good evening, everyone. Thank you so much, Annie, and all the esteemed leaders here. My name is Mary Elizabeth, and I'm from Medlearn, Bangalore. So, ma'am, I have these quick questions. Training, how much or what is your suggestion in the hospitals funding the nursing training? Let's say we already have nurses in the hospital. Like many of our leaders spoke about retaining nurses, retention. So what can the hospitals do, and is something really happening with all your experience in terms of the specialty or career pathway based programs which is funded by the hospitals? Therefore, you can retain nurses, and that's a motivation for everyone. That's one. Okay. And second, the quality indicators which are nurse specific or driven by nurses. So when we say nurses are responsible, what is the role of other stakeholders? Because when you talk about quality indicators, the entire burden shouldn't be on the nurses. So how much is the other contribution from the stakeholders? Therefore, nurse has the ease to take the responsibility, and should they also be given the authority to question, which everybody should know. The last one is psychological safety. So with your experience, there must have been a crisis situation or an error which a nurse would have possibly got into a situation like that. So definitely leaders, all of you here, would have handled that situation very beautifully. It is challenging. So that particular nurse who has experienced this, and what would be the influence on the atmosphere, the entire team as such? Because if an error happens, the people are scared, they would want to go off, but you would have handled it very well. So these are things. That is it, ma'am.
Okay, so whom do you want?
Anybody.
Anybody can answer. So first question probably I will answer. That is related to training you asked. What is the stake of stakeholders in bearing the cost of training? That was your question. My answer is that it depends on the healthcare organization. In government healthcare, whatever training is done, it is part of your duty, and you are deputed to do the training. It is not done out of the duty hours. But when it comes to private healthcare, as there is resource issues and their ability to send nurses for training either may be limited, or it doesn't find a result because of nurses not staying on. I will invest, all of us face this problem. We invest hugely in training because when the nurse comes as a novice, do not know to practice anything. They have not seen patients, mind you. They have not even seen patients or touched patients in their life. And we are committing our patients in their care. So you think without any training we can give them our patients? We are answerable for that patient's care because we are taking money. But however, we do invest in their training. But what do we get in return? So every nurse who is availing this benefit of being trained by the private healthcare system should ask themselves. Today there is no compulsion. They can go off whenever they want. But the only way for the health system to assume the cost would be that nurses behave in a responsible manner. Let me put it very bluntly to everybody. That nurses taking the benefit of either the government spending money on them or the private sector spending money on them or their parents, whoever, spending money on their education and further education after coming to the hospital. Once you gain competence, no return back. No returning back to the institution. So it is time for reflecting on our own behavior. Okay, so that is my answer. So there is no yes, no answer. If it is affordable, they'll do it, or it is the smartness of the nurse leader to get it out of the, but nobody will give you just like that, right? You have to assume it.
Yeah. To just add this one, I do not know how many of you are aware of it. TNA created the learning management system. As we keep hearing that knowledge is a power, I need to equip myself. And as we all are the educated nurses, please go through the TNA website. If you are a TNA member, more than 500 courses are available. And the pre-test and post-test, everything, because we need to equip ourselves to better more. As well as TNA also giving the research grant. And because it's available, previously it was not there, to 2020 onwards, we are giving. We love to give more grant on, mainly on we are focusing on the evidence-based nurse midwifery practitioner. And third thing, TNA also is offering the TNA fellowship, because very soon the guidelines will be published, and if anybody interested to equip themselves, and TNA is giving a grant. Another one more TNA is doing also, we are also sponsoring the nurses for the IAS officers. Because morning we said that some of the nurses are good at it. Because why we have taken up this one? Because many feel the doctors are the IAS officer and they are supporting the doctors. Why not nurses? Nurses are not less than anyone else. So TNA has come forward to sponsor the nurses. Again, the public application will be coming. And if you are preliminary pass the examination, and you will have that means a privilege to come and stay in the headquarters, and we will be supportive with the financially also, part of the things and everything is there. So work on it, and if anybody is coming, because in future, we are going to see the different things. One nurse made a change, Florence Nightingale. 200, that means 9 nurses made a great impact. We are the 30 lakhs nurses in India. Let us make something else. Let us empower ourselves. And I want to just say 4 things. Let us equip ourselves with a head full of knowledge, because keep changing, everybody's keep changing. Many things which I have learned now, that has to be translated to heart, second H. Because we as a nurses cannot work only with the power of knowledge. That has to come to the characteristics of all the knowledge. Third, hand, put it in action. We are very much interested in teaching, but we are not going to put in action. We need to bring the gap between each one of us. Whatever the position we are in, and that is a hand, the practice. That has to be our habit, not only for the ANEI, that means, and the auditing and all the other things. This all has to be our habit. Whatever the position, whatever the designation, we need to feel pride to say that, wow, I am a nurse. Once we feel that feeling, the way we do everything, whatever the position, whatever the designation, the way we do everything will be changed differently. And I always say that to the doctors, sir, you are only responsible for only 15% that's cure. And I, as a nurse, responsible for 85% care. So once you equip that one in our mind, I think the knowledge, the heart, we are better than any other profession, and that has to be put it in action and has to be in practice. I think we will win over every situation as a
Thank you. Very nice answer. To your second part of the question, I will not take third part. First of all, I would request Madam Abadi to answer. Her question was nursing-related quality indicators. Many of them are associated with many other stakeholders. Say patient fault. It's not only nurse's fault. No, so how do we fix that accountability? Why are only nurses questioned about it?
The quality indicators which are specific to nursing have been put as nursing quality indicators. Now, if we say a patient's fall, many times I have found that the patient fell because the family member did not accompany. But is the family member accountable in the hospital when the patient is there, or am I as a nurse accountable for the patient when the patient is there? So when we do root cause analysis, we need to find out what was the process which went wrong. Was the assessment not done? Was the fault score not established correctly? All these are nurses' responsibilities. And then comes the education of the family member, or keeping alert, or making sure that even during the night time, one of the nurses can be in the room so that we avoid the patient fall. So accountability has to be taken. If we are here talking about being independent, taking responsibility, we have to be accountable. Other quality indicators like pressure ulcer. Yes, of course, nutrition and all these other factors are there. But if we don't term the patient, if we don't give the regular back care, if we are not vigilant, each shift, each nurse, then the accountability definitely has to be. We have to take accountability. We cannot shirk it. That is my strong belief, that when it comes to the bedside, nurse is there 24/7. Therefore, we have to take accountability.
Yes, so the answer is that accountability remains with nursing. If the problem through a root cause analysis, you identify if it is with somebody else, it is our own responsibility to fix it. We can't say that they did not do their job, so patient fell, or so patient had bed sore, or etc., etc. So accountability remains with nursing, hence it is known as nursing-related quality indicators. Okay. Do we have to take one more question, ma'am? I'll take the next question, you can answer.
Ma'am, good evening, ma'am. This is Shobha from Care Hospitals, Hyderabad. One small question. What would be the future goals of ANEI, ma'am?
Future goals of ANEI, that's what you asked. What is the future of ANEI? That is the future goals of ANEI. Future of ANEI, if you ask me, future is bright, so I am in this organization. Just to put it in one word, but the future is as good as its members, let me tell you. If there are more members, more active members, not just paying, if more active members, you are willing to work along with the senior leaders sitting here in this hall, the future is very bright. You know, the nursing is, to be a nurse, this is the best time, I tell you, because all over the world, nurses are wanted. And what better can happen in a human being's life than getting into a profession which the world wants?
Yes.
Isn't it? So we are in the best of time, but if you expect someone else to turn around the world in favor of you, that is not going to happen. So the responsibility lies with each nurse. Current nurse, future nurse, everybody. Okay, or past nurse, whatever. The responsibility lies with each one of us. So ANEI's future plans are in alignment with the idea of making nursing, having nursing a better status, better acknowledged, ensuring their rightful position in healthcare. That is our vision. But for that, one or two or few, 10, 20 people are not enough. We need a unified voice. We need to associate with other associations, not only our sister associations like maybe TNAI, Critical Care Nursing Society, but also with the entire healthcare workforce, because everybody is dependent on nurses and we are dependent on them too for better patient care, right? So, synergizing the energies is our future course of action. So what we did for that, I'll tell you from last year onwards, we have started engaging other people in healthcare, means our sister concerns, our colleagues in other professions, more into our daily activities. Whatever we do, there is patient today, there is doctors, there are management, HR people, IT people, everybody is there. Even here, if you go through the program, you will see that. So we are trying to synergize the energy so that the outcome is better than we struggling ourselves alone in silos.
Thank you.
I hope I have answered your question. Do we have more time? No. So they have vetoed, there is no more time because we have to be, keeping up with the time.
In one sentence, I will say that I can do wonders, you can do wonders, we all can do wonders. So that I, you and me come together, we can do wonders.
Yes, absolutely, I agree with Madam. Any parting comments? One sentence, please.
Just someone asked about the future of ANI. She said very rightly, it's in our hands. And what I think is training, skill development, that is the main thing what will make a difference of the image of the nursing over here in India. So training is something I think each one of the organizations must take it as very, very seriously, very seriously. That will only make a big difference. And I think ANEI is definitely going to work much more towards this particular aspect.
Ajita, 30 seconds to answer one quality indicator question, which is a burning question.
Please.
There are processes, especially I work for that organization, where quality indicators of various departments dovetail into the final score, and every individual department gets the same ranking for the overall score. So right from the CEO to any other department is a stakeholder for every quality indicator.
Yes, yes.
And
Fixing
it's equal
accountability.
distribution of increments
Yes.
based on that
So
performance.
it is made very clear to everybody that their role has to be done in order to achieve the outcome.
Overall outcome of the
Overall
organization.
outcome, yes,
So even if my department fails, the CEO gets affected.
Absolutely.
The CEO fails,
Vice
my
versa
department.
too, vice versa too.
Second thing, I think one question didn't get answered was about the error. I think today we've come a long way. There is a second victim policy, so probably that was not answered. So I thought, yes. So we can discuss offline.
Due to paucity of time, I just skipped that question. Ma'am, the last comment from Madam Abadi. Then we will wind up this.
My comment is my strong belief that whatever you learn, put it into practice. If it cannot be practiced, don't teach it.
Thank you. Thank you very much, ma'am. Very powerful statement. And she is a living example of what she said. And all of us are trying to be following her footsteps, actually. Madam is somebody who has personally influenced me a lot. And I'm sure a lot of disciples of Madam Abadi Goman is sitting here. So looking forward to learning from you more, ma'am. And thank you, everyone. Thank you for the questions. And thank you for the answers. Over to the next program. Thank you.
Wow, this has truly been a splendid session, imparting us with invaluable lessons. Thank you, leaders. Can we give them a round of applause? We request the leaders to pose for a photo at the photo corner. We are coming back to our ANEI sponsors. We are happy to have with us Ms. Kavita Krishnan, Managing Service Excellence, Apollo BGS, Mysore, representing Life Science, who will be briefing on Busy to Brilliance, Enhancing Care with Technology. Life Science is sponsoring our networking dinner this evening. Over to Ms. Kavita Krishnan.